Kathy, if you're good, I'm going to go ahead and get started with the intro. That way we have enough time for Q&A at the end.
Okay.
Perfect. Good afternoon, everyone, and welcome to today's webinar. My name is Chelsea Townsend. I'm the director of the South Carolina Prescription Monitoring Program, and I also chair the NASCSA Education Committee. I'll be hosting this afternoon's webinar along with NASCSA's Kathy Keogh. Hopefully you read through the scrolling material while waiting for the webinar to start, which provides information regarding our sponsors, a NASCSA disclaimer, housekeeping items, and announcements. I wanted to let everyone know the dates of this year's 2025 conference are October 20th through 23rd in New Orleans. The hotel information is already posted to the website, but I would encourage everyone to book as early as possible, at least for the hotel. Our hotel block is already 3/4 of the way full, so we want to make sure that everybody's able to book at the hotel where the conference is going to be held. Today's webinar and all of our webinars throughout the year would not be possible without the generous support of our sponsors. So thank you to all of our sponsors, and thank you for taking the time out of your day to join us for today's webinar on the use of stimulants in the treatment of attention deficit disorder and beyond. We're excited to have Dr. J. Craig Allen, so please allow me to introduce him. Dr. Allen is the Medical Director of Rushford Center, Chief of Psychiatry at Midstate Medical Center, and Vice President of Addiction Services for the Behavioral Health Network of Hartford Healthcare in Connecticut. As co-chair of the Opioid Stewardship Committee, he organizes the annual HHC Opioid Symposium addressing quality and safety issues in the management of pain and addiction. Dr. Allen is on the State of Connecticut's Alcohol and Drug Policy Council, co-chairing the Treatment Subcommittee and on the advisory board for the Department of Mental Health and Addiction Services. He is also the immediate past president of the Connecticut chapter of the American Society of Addiction Medicine. Dr. Allen served as the expert consultant to the Connecticut chapter of the American Academy of Pediatrics Clinical Quality Network Practice Improvement Project addressing adolescent substance use, and was the substance use disorder consultant for the state's Child and Adolescent Psychiatry Access Mental Health Program. Dr. Allen is board certified in child and adolescent psychiatry, adult psychiatry, and addiction medicine. Dr. Allen has held faculty appointments at Harvard and Yale Medical Schools and is currently an assistant professor of psychiatry at the University of Connecticut School of Medicine and associate professor of psychiatry at Quinnipiac University, Frank Netter School of Medicine. Currently, he trains addiction medicine fellows in Rushford's ACGME accredited program and child and adolescent psychiatry fellows and psychiatry residents from the Institute of Living. In addition, Dr. Allen lectures and advocates locally and nationally for prevention, screening, early intervention, and treatment access for substance use and other psychiatric disorders throughout the lifespan. He sees patients at Rushford and through his private practice in Branford, Connecticut. So welcome, Dr. Allen, and the floor is yours.
Thank you very much, Chelsea. Wow, I feel like we should just drop the mic. That's more than enough for me. I appreciate it. Thanks for showing up. Have a good day. But no, I'll actually give this talk. That's really nice, though. That was very some. Wish my mother was alive to hear it. So let's see. I don't think I got it yet. Did I? Can you guys see the slides? No. Let me see. All right. How's this?
Perfect.
We can see it.
Excellent. That's usually the hardest part. The rest of this is going to be gravy. So you've had my introduction. At the end of this presentation, I did mislead a little bit on what I'm going to talk about today. I'm just going to show one very quick slide on medical indications for treatment with stimulants. I am going to focus today on talking about diagnosis and treatment of ADHD, and the focus there is going to be on medication use, and the focus there is really going to be on stimulants used to treat ADHD. I'm going to have three different cases that I present. One will be a child. The second one will be a younger adult, and the third will be a patient who has a co-occurring substance use disorder. And I'll talk a little bit about the approaches and the things you got to look at in that one who treats those patients thinks about when they're prescribing those medications and trying to help that patient do the best, that person do the best that they can. Number 3, I'm not going to talk about, which is guidelines for treatment of stimulant use disorder. There was a seminar that covered that for you guys a while back, and those guidelines are available online. The American Society of Addiction Medicine came out with those guidelines, maybe about a year or so ago. That's it, but that's a complete talk in and of itself. So I'm going to talk, here's your slide with the different conditions that are approved by the FDA for stimulant treatment, and a number of different stimulants listed there. I didn't list all the stimulants approved under each category. I'm going to move on to talk about attention deficit disorder. So the numbers are rising of people being diagnosed with ADHD. And there may be a number of different reasons for those numbers to be going up, but they are. And 6% in 1990, 11.4% nowadays. That's adults and kids. An increase in 7 million from 2016 to 2020. Boys more so than girls, and Black and white children about the same numbers. Asian children diagnosed much less frequently. And with adults, 1 in 17, 15 million adults. Important to know that ADHD, the condition, always starts in childhood, although half of adults get a diagnosis when they are 18 years or older. So again, the disorder was present, just may not have been diagnosed, if in fact they do have that diagnosis as an adult. So it's a genetic and environmental disorder. Huge weight on the genetic piece, 76 to 80% heritability. If a parent has ADHD, then the likelihood of the kid having ADHD, if one parent has it, likelihood's greater than 50%. What I find as a child and adolescent psychiatrist through the years is that when I'm seeing a child who has attention deficit disorder, it's very common for the parent or parents to also have attention deficit disorder. That presents a challenge in and of itself. Some of the interventions for ADHD include providing a structured environment, consistent follow-up and expectations, as well as managing oftentimes medications. And that means getting the prescription and making sure that the kid gets the prescription. If you are an adult with attention deficit disorder, particularly if you're not being treated, then managing those things is going to be quite the challenge. So the whole family oftentimes presents with these same symptoms. Environmental contributors I have listed up there, prenatal exposure to tobacco, alcohol, cannabis, other drugs, environmental toxins, complications during birth or pregnancy, anoxia, exposure to lead. Also, psychosocial adversity and high levels of family conflict. That's when that's either intrauterine or very early on for a child that's going to develop ADHD. So here's some cartoon drawings of different sections, different parts of the brain. And imaging studies show that there are alterations in brain structures and in functional networks that suggest both cortical dysfunction and abnormal connectivity. Maturational delays in certain anatomical brain development and developmental patterns are correlated with clinical functional outcomes. Some studies suggest that this is a developmental disorder. Well, many studies, this is a developmental disorder. And some studies show that with brain imaging, thinning in the prefrontal and parietal cortex, areas they're heavily involved in self-control, so impulse control, planning, organization, and managing emotional reactions. So the three areas of structures, you can put them into three different baskets as a way to try and understand attention deficit hyperactivity disorder. With those cartoons, those first two cartoons show in the upper left-hand corner show the structures that are usually thought about when looking at people with ADHD and imaging with ADHD and talking about the neuroanatomy. The third slide over on the top looks at the noradrenergic and dopaminergic innervation of those areas. And in fact, those are the neurotransmitters that are impacted by all the medications that we have for ADHD. So back to these networks, you have the default mode network, this idea that these areas of the brain that are thought of as the default mode, and that's on the bottom row, the three on the right-hand side in the bottom row. The default mode network, those structures are more active when people are daydreaming, when your mind is wandering or you're deep in your own thoughts, that area is activated. And the executive control area is less activated. When you're looking at a specific task, your default mode network is less activated and your executive control network is more activated. So when you have dysregulation between managing the default mode network and switching between that and the executive control network, you can have a distractibility, difficulty paying attention, particularly in situations that may be less interesting or motivating. So I always think about calculus. The third area or network is the reward system. So the reward pathway, that's the bottom row here, far to the left. There's your reward pathway in the brain. That is the part of the brain that has to do with motivation, with learning. Substances that people can misuse or become addicted to also modulate that area. In fact, they simulate the activities and the behaviors, the release of dopamine, for example, that occurs when you engage in life-sustaining activities like procreation and eating and taking care of your young. Dopamine is released and your brain learns that this is really, really important and you're really, really motivated to engage in those activities. A thought with attention deficit, people that have attention deficit disorder is that their reward pathways may not react in the same ways as someone that doesn't have ADHD. So praise, like for, oh, you did really good on your homework, or, thank you for cleaning up your room, that causes someone to feel happy, to feel good. You release dopamine. It's rewarding. You want to try to do something again to get that kind of praise. Someone with ADHD may not get quite so much dopamine, and likewise, for negative reinforcers, they may not have as much impact. So you do something, you get into trouble, you want to avoid doing that again because of this reward pathway. Someone with ADHD, though, may not be as affected or impacted, and so might not be as averse to engaging in that same activity. I mentioned earlier dopamine and norepinephrine. Those are the neurotransmitters that are impacted by all of the medications that we have to treat attention deficit hyperactivity disorder, despite the fact that we have all of this imaging and neuroanatomical structures. that are different in people with ADHD. The diagnosis is still a clinical diagnosis. There's not a blood test. There's not a brain scan. The diagnosis is made clinically, which means that it's not that hard to mislead your treater into believing that you might have ADHD if you learn the right answers to questions. You can certainly lead the medical provider to that conclusion. The diagnostic criteria for attention deficit disorder for adults, so over the age of 17, 5 symptoms from the inattentive or hyperactivity component. You have to have 5 in order to meet the criteria. For children, you have to have, you need to have 6 for adults, 5 for children. I'm switching it around. Yes, that's right. You have to have had these symptoms for more than 6 months, but don't forget that I said the symptoms are always there before the age of 12. They're always there as a kid. Even if you're being diagnosed as an adult, you've had those symptoms that may not have been picked up on, or diagnosis may not have been made. And they have to be present in 2 different settings. So for an adult, at work or at home. For a kid, in an academic setting, maybe in social settings, but you have to have 2 different settings. There's 3 different types of ADHD. There's the inattentive type, there's the primarily hyperactive impulsive type, and then there's the combined type, which is probably the most common presentation. So why do we care about diagnosing ADHD? Well, because it's important to identify and treat ADHD, because there are consequences when that doesn't happen. This was just a study on kids who were not diagnosed and were not treated, 10 and 12-year-olds. They had this is from 2019, a study, lower self-esteem, higher levels of depression, more mood symptoms, and higher risks of self-harm. People with attention deficit disorder are much more likely to get into accidents and be injured. Impulsivity, lack of planning, almost double the risk of injury in people who have ADHD and untreated ADHD. When people have treated, are getting medications for ADHD, those rates of injury decrease. On the right-hand side of this slide, we have a slide showing the onset of substance use problems. There is a large percentage of people with attention deficit disorder who have substance use disorders, and vice versa. Large number of people that I see in our treatment facilities for substance use disorders that have a co-occurring attention deficit disorder. This comes up from time to time. If you use a controlled medication to treat a child or an adult's attention deficit disorder, won't they misuse those medications? Won't they have a greater likelihood of developing a substance use disorder? This slide here shows the onset of substance use in untreated ADHD adults versus the general population. You see the rates are much higher. The next slide addresses the issue of, well, does giving a controlled substance lead to more substance use disorders? In fact, a number of studies have shown that it's probably the opposite. If you are treating the attention deficit disorder, even though there's a high degree of comorbidity with substance use disorders, there's less of a risk of misusing that medication and developing other substance use disorders if you're actually treating the ADHD. This was a study that came out last month. Also, similar studies have been done in the last 10 years, looking at decreased life expectancy for people with ADHD. This study came out of the United Kingdom. but this study and prior studies are consistent in that it appears having attention deficit hyperactivity disorder reduces life expectancy by 7 to 9 years. It's probably caused by this loss of years of life, probably caused by modifiable risk factors, unmet support and treatment needs, both for ADHD and co-occurring disorders. I mentioned co-occurring substance use disorders. There's also a high level of co-occurring other psychiatric disorders, and I've got a slide on that a little bit further. Russell Barkley has been a guru in studying ADHD. And he had a similar study about 10 years ago that showed a 8-year decrease in life expectancy. And he talks about males with ADHD being more likely to engage in risk-taking, being more impulsive, having accidental injuries, and other things that can lead to mortality, early mortality. With women, who have ADHD, more psychological stress, anxiety, depression, sleep disturbance, eating disorders, self-harm, and problems with relationships and mood regulation. That's why it's important to identify, and that's why it is important to treat ADHD. So how do you diagnose? How do you assess? How do you treat ADHD? There are some guidelines for children and adolescents. The American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry have practice parameters. The Society of Developmental and Behavioral Pediatrics has practice parameters and guidelines for more complex ADHD. There are not guidelines for diagnosing in adults, but they're on the way. The American Professional Society of ADHD and Related Disorders is expected to come out with guidelines soon. So I would guess that they would be coming out this year, and then we'll have some guidelines for adults as well. I'm going to talk about this first scenario, which is a 7-year-old second grader named John, who is brought to the office with the chief complaint that he has difficulty staying on task. He's fidgety, disruptive, both at home and at school, trouble following through with his chores, trouble staying focused, and as you can see, he's easily distracted when he's supposed to be working on his math problems or science right there. So in the evaluation, medical and developmental history are important to look into. Kids who have hearing problems can present as though they have attentional problems. Kids that would have tubes, multiple rounds of tubes for ear infections could ultimately be at risk for hearing problems, and that can make someone like inattentive and distracted as well. Kids with anxiety disorders or learning problems can present as though they have attention deficit disorder. Now, I mentioned there's a lot of comorbidity, but those disorders can present as looking like they're ADHD when in fact ADHD is not present. Also need to rule out other potential medical causes and psychosocial issues, problems at home or traumatic situations or recent death of a caregiver. Those kinds of things can all present looking like ADHD, so it needs to be evaluated. John here has school history, average cognitive abilities, reading and math skills are average as well, but grades are inconsistent, and he needs extra help staying on task, getting his assignments done. Repeatedly needs to be reminded about the directions and to sit quietly during lessons in school. His behavioral impulsivity and challenges sometimes reading a social situation can be disruptive and cause problems with some of the other kids. So he's starting to be ostracized, and kids aren't choosing him first to be on their computer team or whatever they do in second grade. Family history, as we mentioned earlier, very important. John's father was diagnosed with ADHD, but no other psychiatric issues in the family. In the office, John is very energetic, a difficult time sitting still. When he does sit still, squirming around in his chair. I am a child and adolescent psychiatrist, so I have different toys and things in my office, and sometimes I regret that when I'm seeing a kid who has significant impulsivity and hyperactivity because they're constantly getting up and playing with things in my office. I learned that sometimes I need to clean up some of the stuff and decrease the number of distractions in the office if I want to try to get through the evaluation. Trying to get John to sit still and complete like simple puzzles and stuff, quickly get frustrated. Didn't present as having other psychiatric symptoms at this point in time. Behavior rating scales are really important. The Connors evaluation is one that is done for kids. The rating scale is usually given to the parents or the caregivers and to the teacher. So that combined with the in-office evaluation can help you to make a diagnosis. John met the full criteria for DSM-5, what I showed you earlier, and was diagnosed with combined type ADHD. These are a list, some bullet points of the interventions that are put in place, but I told you earlier, we're going to focus on the use of medications, and within the medications that are available, we're going to focus on the use of stimulants. But these other bulleted points are all incredibly important and necessary. This is just a picture. There's the Connor scale on the left. That one's for the parents. There's another one that's a little bit different for teachers to fill out, and you can generate a number, and that number can actually be tracked as you're providing treatment, and you want to see the number go down. On the right is a scale for adults, which you can find that online too. Also can be used to track the effectiveness of your treatment. This is just to show you you've got a number of medications to choose from, but primarily what we focus on with stimulants is the amphetamines versus methylphenidate. This little study here has atomoxetine, name brand Strattera in there, and looking at the effectiveness, and in this study, it looks as though amphetamines are probably the most effective, closely followed by methylphenidate. And you guys are pharmacists, there's a little bit difference in their in the way that they impact neurotransmitters. Amphetamine is approved for kids under the age of 6. Methylphenidate is 7 and older. So in our kid here, we can choose either one of these medications because they're both FDA approved for this age range. I mentioned the medications are available in immediate release and in long-acting forms. Always start at a low dose and go slow, and monitor for efficacy as well as for potential side effects. I'll talk about those in a second. Consideration with a child who's in school also is if you are using an immediate release. So immediate release, 3 to 5 hours works for, but that could be variable, versus the extended release, which could be 6 to 9 hours, but that could be variable, and manufacturers have different claims, but the experience is really an individual one. Kids, if they have to get multiple doses during the day, during school, that means that they have to get up and leave class and go down to the nurse's office to get that medication. That could be pretty disruptive and stigmatizing. So the goal would really be to try to use a long-acting medication, maybe starting with the immediate release to see what dose might be most effective. But the benefits of dosing in the morning and not having to redose at school are significant and should be considered. Informed consent, very important. Talk about potential benefits, of course, but also the potential risks with the parents and the guardians. things like the risk of misuse, and the impact that can be had on sleep and on appetite and on growth. When you first start, you see someone more frequently, you can see them less frequently later. I myself personally don't see people less than once a month, but there are many other practitioners who, once they're comfortable with the dose, will see someone every 3 months, and I think pediatricians would certainly lean in that direction. I mentioned using the scales to monitor. You're looking for those target symptoms, always helpful to identify what the target symptoms are with the kid, age appropriately, and with the parents as well. Some of the side effects we're concerned about are decreased appetite. Decreased appetite can lead to lack of weight gain or weight loss. And there are a number of studies that have shown, particularly if a kid does not have drug holidays, that there can be an impact on adult height of 1 to 3 centimeters. So important to watch closely and think about drug holidays if the child does not need that medication to function, say, on a vacation or whatever. But I've got plenty of patients that I've treated, and the family insists appropriately that they be on those medications on those holidays too. Not all kids have to have lifelong treatment with ADHD medications. I mentioned it's a developmental disorder, so as the brain matures, those parts of the brain that can exert better control over impulses may win out, and kids may not need medication as they get older and move into young adulthood or adulthood. There are a number of other medications that can be used both with stimulants or in lieu of stimulants, but I'm not going to focus on those right now. I'm going to talk about Jill. So Jill is a 29-year-old account executive for an advertising firm. She comes to the office. She's really having a lot of trouble getting projects completed. Obviously, this is somewhat of a change in her functioning. She's forgetting things at work, and recently she got engaged. She's trying to plan her wedding and deal with the in-laws, and it is all, she just feels overwhelmed. She gives you a history of difficulty focusing and paying attention, most noticed by her right around the time of the onset of COVID. Her business, as many businesses, went online. She found herself distracted by things in her home environment, by social media, video games. She'd be on a Zoom call and she's looking at her phone, or she's looking out the window, or she's looking at the birds, or she's doing other things. And then even when she got back in the office, because it was a hybrid model, in and out, she would continue to struggle with these meetings. And now with the upcoming wedding, she's really feeling overwhelmed. She read an article about adult ADHD, and so she came in for an evaluation. I was able to talk to her and her mother, as well as her fiance. The inattentive symptoms appeared to have been present when she was a kid and she was in grade school. Would come across more as daydreaming, or we saw that she was just quiet and shy. This is not uncommon for girls to be missed and overlooked because they less often present with the impulse, the disruptiveness and the hyperactivity. When you're disrupting the class, you're going to get the squeaky wheel gets the oil. That's what my mother always said. So if you're causing a problem in the classroom, there's going to be many more complaints, and something's going to have to be done. She got involved in sports, which was incredibly helpful, and exercise is really, really important for ADHD and many other psychiatric disorders, very beneficial. She also got involved in music, so she had a very structured day. That's helpful and important for someone with ADHD. In college, she continued to do her intramural activities. She had friends, but she did spend a lot of time working on projects, much more than her peers, and a lot of time studying alone. So she's trying to manage her ADHD on her own without the diagnosis. But despite all the time that she spent, she got average grades. She was picked up by an advertising company, and because of her energy level and her creativity, she rose rapidly to become one of the ad executives. Medical workup for her. She's not pregnant. She doesn't have Lyme disease here in Connecticut. Everyone's got to rule out Lyme disease. There are no other medical problems that were identified, no allergies. Some screening tools were used for depression, anxiety, PHQ-9, GAD7. And they showed low levels, but not necessarily clinical levels of depression, I always say at this time, because untreated, it goes on. This slide here is just to show you some of the comorbidity with ADHD and other psychiatric disorders. Along the bottom, we have on the far right, depression, anxiety, substance use disorders, personality disorder, bipolar disorder, schizophrenia. The bright red circles are women with ADHD. You see the comorbidity of women with ADHD being much higher than women who have, for depression, the comorbidity of depression, much higher than for women who don't have ADHD, which is that faded pinkish circle down near, what is that, 8%, 7-8%. And so this illustrates the comorbid, the rates of other psychiatric disorders in people diagnosed with ADHD. And the importance of needing to look for those, both when you're treating somebody, before you start a medication, and continuing to monitor for those comorbid symptoms after you have initiated the medication treatment. Her diagnosis is attention deficit disorder, inattentive type. Start low, go slow. She started on a long-acting medication, and she did very well. She was able to get back on track at work and get things planned for and deal with her mother-in-law. Important to reassess regularly for the target symptoms, make sure the medications are actually doing what they're supposed to do. And you can use those scales. Follow-up appointments, again, I see people minimally once a month, starting the medication more frequently. If I have concerns, I'm going to see them more frequently. Insomnia you want to check for. It's really important that someone is sleeping well at night, because that can impact any of our attention spans, make all of us distractible. If you have ADHD, it's worse, but a good night's sleep is really, really important. Monitoring for weight loss, monitoring for mood changes. The thing that bothers me, concerns me most, is if a child or an adult develops mood changes. So whether they're depressive symptoms or irritability or anger, I'm really concerned about that, and I'm going to get that person in and probably hold off on the medication until I know what's going on. Cardiovascular monitoring is important. As you know, the stimulants can raise blood pressure and heart rate, so important to track that. These are some signs and symptoms that maybe you're going to need to monitor closer. So these are not diagnostic. These do not mean that the patient is misusing the medication. This doesn't mean that the patient has developed a stimulant use disorder, but these are the kinds of things that you hear or you see that require further exploration. Taking higher doses than prescribed, skipping doses and trying to use the medication as needed. I'm really uncomfortable with using controlled substances like the stimulants for ADHD as needed, because it can simulate a pattern of recreational drug use, where you're using the substance to party, that kind of thing. So I really don't like the as needed. We say in the substance use treatment arena, we want people to talk about what's going on, talk about their conflicts, talk about their feelings. We want things to come out of their mouth and not just go in their mouth. And so you think of someone who's drinking or using substances. When they use those substances, they're pushing everything down. I don't want someone to be using their ADHD medication to manage their emotions, their feelings, their energy level. Those are all concerning. Early refills, lost medications, tolerance. You shouldn't build a tolerance to the effectiveness in improving attention, the decreased distractibility, the impulsivity. People don't need higher and higher doses to get the same results for ADHD symptoms. People use higher and higher doses of the medication sometimes if they are getting feelings of euphoria, or if they're getting high. If they're using it, recreationally, maybe they will start to get tolerance to those effects and want higher and higher doses. But the treatment of ADHD symptoms, the tolerance that doesn't happen. That shouldn't happen. It doesn't frequently happen. I get very concerned if that's what they're talking about. Feeling anxious or irritable or depressed, I mentioned those. Exhibiting some behaviors that can be consistent with someone who has a substance use disorder, like being really, really worried about missing doses. Again, if you get a medication that's really helpful for you and you're not getting it, you're going to be really concerned about missing doses. So it's not diagnostic, but it's something to look into further. Someone who's losing weight, someone who's not performing as well, someone who's not getting efficacy for the symptoms. Most concerning, and I used to see a group of patients up in Boston who were getting overprescribed stimulants, is the development of actual thought disorder symptoms, suspiciousness, paranoia. There was one year where 3 or 4 patients were hospitalized on the inpatient psychiatric unit I was affiliated with. All of them been seeing the same prescriber who was overprescribing stimulants. And review the treatment plan. I like to say that adults who are benefiting from, if their ADHD symptoms are benefiting from a stimulant, they're likely to continue to benefit from a stimulant for the rest of their lives. That's not necessarily true with kids. Some of them grow out of it. Some of them find other ways to manage things. But an adult who's getting the benefit could probably continue to benefit from that medication for long periods of time. Adjunctive medications are available. Non-controlled medications are available, but I'm not going to talk about those. Psychosocial supports are really, really helpful. Cognitive behavioral therapy or learning organizational skills, time management, coping strategies, those are all really, really really important to consider and utilize, as well as our stimulant medications. I don't know if I mentioned before, but stimulant medications tend to work 60 to 70% of the time, the first stimulant medication you use. And as a young child and adolescent psychiatrist, way back in the day, I used to think, you get a kid who'd come in who was really hyperactive and the parents were going crazy and the school's constantly calling, and we would use Ritalin, that's name brand, sorry, methylphenidate, or a dextroamphetamine or another stimulant, and the symptoms would immediately be reduced significantly. And I used to think, wow, this is my appendectomy. A surgeon can take out a hot appendix and the patient gets well. And this was in psychiatry, something I could prescribe, and the patient looked so much better. I mentioned exercise. Mindfulness practices can be really helpful too. All right, this is Bill, and I'm going to zip through Bill and then see if you guys have any questions.
Yeah, we have about six or seven questions in the chat already.
Okay, I'll get through Bill in less than 5. So Bill's a 45-year-old father of 2. He's married. He owns his own shop. He's a mechanic. He comes in the office and he says, "Look, if I don't get back on my medication, I'm gonna lose my business." And so history, present illness. Going back to his childhood, he was diagnosed at the age of 7, didn't get any treatment, had average IQ, struggled academically, opposition with teachers, got in a lot of fights with peers, kind of a bad boy. Age of 13, started drinking alcohol. Age of 15, was suspended from school for possession of marijuana, got an IEP, an evaluation for his educational plan. I said, "Look, you should be in a Voc school. I think you'll do much better there." He's got untreated ADHD. Would you guys reconsider treating that? And this time the parents said yes. He got on to methylphenidate, got some other supports in place in the classroom, also started in therapy, did very well, graduated top of his class, got a job at a mechanic business right after graduation. And within 7 years or so was able to buy into the business, got married, 2 kids, was always a social drinker. This escalated as his responsibilities increased and a couple losses that he had in his extended family. And it turned into problem drinking, turned into an alcohol use disorder, had a couple of outpatient treatments, but continued to struggle. And there was an incident at work where he got into an argument with one of his employees and the police were involved. And after that, he agreed to go to an inpatient residential treatment program. And he did really well there, was able to stop drinking and continued in outpatient therapy and going to AA, was on naltrexone extended release for his alcohol use disorder, was doing very well, but at work, having a lot of difficulty getting things done, focusing, concentrating, and had a lower level, certainly than when he was drinking, but still had some irritability and some difficulties with his employees, so some emotional dysregulation. Full evaluation was completed. Looked at the prescription monitoring program, saw, yes, in fact, he had been prescribed stimulant medications up until the time that he was in the residential treatment program. I mean, and, his report is he'd gone to 3 or 4 different doctors. They would not prescribe this controlled substance because he told them out front, I have an alcohol use disorder. I'm in treatment. I'm doing well. And they were afraid to prescribe for him because of his co-occurring substance use disorder. Substance use in ADHD, very common. I mentioned that earlier. Number of studies support that. And I had this conversation with my addiction medicine fellows yesterday, said, should we restart so-and-so's stimulant medication? They're finishing up in our residential treatment program, or they'd just gotten out of it. Maybe they're in our partial hospital program. And I said, well, wait a minute, I have a slide for that. And this slide shows retention in treatment. What we know from substance use disorder treatment is the longer you stay engaged in treatment, the better the outcomes are. And this looks at people with ADHD who are getting their medication, staying in treatment, versus people who aren't getting their medication. Lo and behold, people that are getting their medication for ADHD are much more likely to stay in treatment. Therefore, you have better outcomes. And this is just shows, well, when do you treat the ADHD? Well, first you treat the alcohol and substance use. This doesn't really answer any questions for you, but oftentimes we treat, like mood disorders, we will treat concurrently with the substance use disorder. We might hold off a little bit on the ADHD. Certainly, we want to verify that there is an ADHD diagnosis, and we do see plenty of people with substance use disorders who don't have ADHD but have been diagnosed with ADHD, and in fact, their inattention, distractibility, and impulsivity has more to do with their substance use disorder, and it's not helpful to put them on stimulant medications. So Bill got on this medication. Of course, he did very well. And we have him back for follow-up. Someone who has a substance use disorder you may want to see more frequently, And, initially, and you want to monitor more closely. So you may do urine drug screens. In fact, we always do urine drug screens when we're treating someone with a controlled substance who has another substance use disorder. I'm talking about someone with a stable substance use disorder. An active substance use disorder would argue against using a controlled substance at all. Doing urine drug screens, making sure the medication you're prescribing is where it's supposed to be, and making sure there aren't substances there that aren't supposed to be that are going to cause problems. I'm most concerned about stimulants, cocaine, methamphetamine, because that can lead to stroke and death, and that's what we're trying to avoid. Medication agreements can be helpful sometimes. That's not a contract. There's no legally binding component there, but it's you're expected to take your medication as prescribed. You may not get, if you lose your medication, you may not get an early refill. We may want to, if we're going to ask for urine drug screens randomly, It's also important to communicate with the other providers who are there. Efficacy, follow-up, side effects, alternative medications, psychosocial supports. I think I've covered all of that, and that should be it. And I will stop this and we can answer questions.
Yep, they're coming in fast and furious.
Fast and furious.
We're going to try to get through as many as possible. If you can stay a couple minutes
I'll talk
later.
really fast.
Yeah. So the first question is the rise in ADHD generally consistent state by state, or are we seeing any outliers?
I don't have the answer for that. I don't know. I mean, I think it's nationally. There may be places that have, I mean, I don't know which states might be outliers. I do know that there are some problems with online groups that are diagnosing and prescribing stimulants for ADHD, and at least one was shut down fairly recently. But I don't know what parts of the country might be worse. If you know, just tell me.
Okay. And then with the increase in stimulant prescriptions over the last few years, have you seen an increase in stimulant use disorder diagnoses?
We're lucky in the Northeast and in Connecticut in that we do not have that scourge, knock on wood, of methamphetamine use disorder, but we do have cocaine use disorder. Are we seeing more and more people who are having problems with controlled stimulant medications? We're seeing more. We're seeing more. I think that, I mean, we're definitely seeing a lot of cocaine out here, but we're seeing more with the increased prescriptions. I'll let you ask another question. I won't just go off on this, but.
Okay. We see many patients who are on ADHD stimulants that are on benzos and some also on Ambien, which is concerning. Thoughts on this?
Well, yeah, you get really anxious and sped up when you take the controlled stimulants. So you got to calm down with your benzo, and then it's difficult to sleep, and so you take a sleep medication. Yeah, I think that's not a good combination. I'm being sarcastic. It reminds me of I swallowed a spider to catch the fly, that old nursery rhyme. You really have to reassess somebody like that and say, are you using this second medication because the first medication is causing a side effect of not being able to calm down and being racy or not being able to sleep? And these are all controlled substances, and they all pose risks. And yeah, that's not a good combination. That's a very concerning combination. I won't say that there's nobody that would benefit from that combination. That's not true. But I think you really have to do a careful assessment and monitor very closely if somehow you're going to end up on that. I'm not sure anyone could benefit from that particular combination. But sometimes people are on some of those combinations. Again, who's the best person to treat? Maybe someone who's got some expertise in substance use disorders as well as managing ADHD.
Okay. A lot of us in the controlled substance monitoring stewardship world are concerned about increased stimulant prescribing, particularly as often described in terms of online pill mills. Is there anything we can be on the lookout for as regulatory and monitoring agencies? It feels difficult to determine riskier overprescribing versus appropriate prescribing of stimulants from a population data analysis basis?
Yeah, I mean, great question. Probably stuff that a pharmacist already knows. That one list. Some of those things the pharmacist might be aware of. People lost my prescription again, but the doc overrode it, and that is a concern. It's hard to, I'm not sure. I'm sure there's some great answer there. I just don't have it.
Okay. Thoughts on flat effect, irritability, mild depression after years of appropriate use of Adderall, switched to Concerta, and the same thing happened after about a year of appropriate use?
So maybe it's the medication. Maybe the person has depression, and the depression episodes present as being flat and irritable. I would also think about a medication, a non-stimulant medication, something like atomoxetine, which also has some benefits as an antidepressant, which was originally created as an antidepressant. It's not the greatest antidepressant. So I would be concerned about that, and try to get to the bottom of it. Maybe you need to prescribe an antidepressant with a stimulant if the stimulant's really, really important to be on board and you can't find something else that'll manage.
Are there any studies that speak to the patient's experience once the medication is discontinued, like a multi-year post-therapy follow-up? Any idea the rate of return to the need for medication once discontinued?
That's a great question. I don't have those studies. My comments would be, one, when you stop taking a stimulant, there is a withdrawal syndrome that occurs. And so people are sometimes surprised by that. When there are withdrawal symptoms, so, I don't have any energy, I can't get out of bed, I just want to sleep all the time, but that shouldn't go on for too long, so if that happens, you want to see that resolve in a week, but you want to be aware of that, because that can also make the person say, oh, no, I really have to be on the medication because I don't have any energy and I can't focus and I don't get out of bed and I want to sleep all day. You're going to have some withdrawal symptoms. You've been on a stimulant. Let's give it some time. But I'm not aware of a study that looks at who returns to it. I mean, I just comment, what we always said with kids is a third of the kids will go on and really benefit from medications as adults. A third of the kids might be able to develop other strategies and not need to use the medications. They structure their day, they chunk their work, they decrease distractions at times when they're supposed to be focusing, and they can go on to live lives without the medication. And then a third of those kids go on to be adults where you can't even tell they ever had ADHD at all. So it doesn't really answer your question. The only other thing I'd add is something I said earlier, which is an adult that's benefiting from a stimulant medication is likely to continue to benefit from it if they're not having side effects like flattening and irritability and depression.
Is the increased prevalence of ADHD due to improved diagnostic tools only, or is it partially attributed to environmental factors or increased stimuli?
Yes.
Yes. What are some red flags of practitioners overprescribing ADHD meds?
Well, I had that slide that was an attempt at some red flags. And so I would repeat some of those things that I said. Someone who's telling me I'm using this to get energy to get things done. Well, maybe you're depressed, and stimulants generally aren't the way for you. That's not how we want to get you energy. There's too many side effects. Losing my script all the time. This bit about tolerance. I need more. I'm not able to pay attention anymore. A lot of times people that I see will tell me things, and I think, I can't believe you just told me that. I said, no, I can't continue to prescribe this medication for you. How did you use that? But red flags beyond what I had on those slides. I think I would have put it on my slide there. Someone's telling me they need something.
Okay, what challenges do you face with screening? How often are patients trying to fool the prescriber?
If I knew that, I wouldn't be fooled. But I get fooled. I think most of the time people are not trying to fool the prescriber. I think that the vast majority of time people are trying to improve their lives. I tell people, frequently enough, maybe more than one might guess, you don't have ADHD. This is not ADHD. Everybody has periods where they're more distracted or they can't get stuff done, and there's all kinds of reasons for it. I remember when Driven to Distraction came out, John Rady's book, it was a bestseller, and I think his follow-up book was too. And suddenly everybody had ADHD because they read the book and they read the symptoms. They said, "Oh my gosh, I have ADHD." But you have ADHD when you have all of those symptoms, and they've been around since before you were 12 years of age, and they significantly and negatively impact at least two spheres of your life. That sounds fairly simple to meet those criteria, but my general experience is that most people aren't trying to fool me. That's how good they are at it.
What percentage of patients actually come off of ADHD meds?
About 100%. So what do you mean by come off of ADHD meds? I think that any medication I prescribe for any reason, my patients do not take it every single day for the rest of their lives. People may use the ADHD medication for a few years and then they don't want to use it anymore. And there's all kinds of reasons they don't want to use it anymore. I don't want to be dependent on this drug. It costs too much. I don't want to pay the copays. I don't want to go to the pharmacy, even if they're getting home delivery. So I'm being facetious, say 100%, but I'd say it's very frequent that people will not continue to see me every month or even every 3 months for forever. For one reason or another, I mean, they tend to stop, and some of them will come back and say, "Oh, I just can't manage," but most of them don't. Most of them that stop don't do. Now, I have patients that I've seen for 5, 6, 8 years on stimulants. They're adults and they continue to come. So, and I don't want to paint the wrong picture, but I think that the majority of folks don't continue to take stimulant medications as adults for. I mean, there must be a study somewhere, but for 10 years. But for a period of time, it may be very helpful.
Perfect. And then last question is, how often do you end up switching from one medication to another to treat ADHD, and does it have anything to do with age or sex?
I guess fairly often, especially when I'm starting someone on a new medication. By fairly often, 30% of the time, 40% of the time. So I try extended release, name brand Concerta, and we switch over to name brand Adderall extended release. Oh, by the way, I always use extended release in someone who has a substance use disorder if I'm going to use a stimulant at all, just by the way. It's really kind of dangerous to use an immediate release. Then maybe we'll switch to Vyvanse. And I have patients that say to me, that's so much smoother on and off, insert whichever medication name you want. So, fairly often, maybe 30% of the time, it's not, oh, you've got ADHD, here's your medication, I'll see you in 3 months. And I tend to treat being first and foremost a child psychiatrist. I mean, I was first a child psychiatrist. I was first a child, then I became a doctor, and then child psychiatrist. But I always start low, go slow anyhow. And I tend to be, in some ways, more conservative, maybe in some ways less conservative, because I'm also an addiction medicine doc. So I'll treat these patients that are complicated and have co-occurring disorders and so forth. But yeah, there.
Okay. Well, once again, I want to thank you, Dr. Allen. This has been fantastic, and we really enjoyed having you. I feel like clearly by the Q&A, the audience also enjoyed having you. And thank you, Kathy. This has been an excellent education for NASCSA membership. So on behalf of NASCSA, I would like to thank everyone who joined us for today's webinar. Again, thank you to our sponsors for making today's webinar possible. And then we wish you guys a wonderful rest of your day.
Thank you.
Thank you.
Thank you.